Morning. Rahul, I didn't receive the OT list today. Am I in any case?
Yes, sir. First case, sir.
What time is it?
So 8:45, sir.
Okay, thank you. Santosh, you can start.
Good morning, sir. Today we are going to talk about the wrist joint anatomy. And wrist joint is also referred to as radiocarpal joint, and is a condylar joint, synovial joint of distal upper limb, connects the and serves as a transposition between the forearm and the hand. The wrist joint consists of distal end of radius, ulna, 8 carpal bones, and proximal base of 5 metacarpals. The carpal bones are categorized as proximal row and distal row based on their kinetic behavior during the global wrist motion. The carpal rows bones can be described as intercalated segment because no tendon inserted upon them, and their motion is entirely dependent on the mechanical force from the surrounding articulation. The distal row carpal bones are tightly bound to one another via the stout intercarpal ligament, and the joints between them are considerably negligible. A short history of wrist joint by James. In the wrist joint is derived from English word, Teutonic word, rest, and Old English root for rest, wrestle, writh, and twist. In French, poigne derived from the root for the strength and power. In German, hand gelen and hand wrestle obviously refers to the joint connecting the hand to the forearm. The corpus originates from Greek karpos, which is variously interpreted as fruit or a small bit of wood. In Spanish, muñeca is also a word for a doll. It is thought that it's derived from the pre-Roman word bonque, which was preceded by Celtic bodcast. It has translated as sight with lumps. Drawing of the wrist bones appears in De Human Corporis Fabrica Libre Septem, book 7, published in the year 1543. In that book, they are numbered from the scaphoid to pisiform as 1 to 4, and from trapezium to hamate as 5 to 8. From the picture, the name for the carpal bones are named by in the year 16th century and 16th and 17th century. Lyser was the first person in 1653. He named lunate and trapezium and trapezoid. And later, Alexander Monroe in 1726, he named scaphoid, pisiform, and he transposed the trapezoid of Lyser to trapezium and trapezium to trapezoid. And in the same year, Albinus named captate and triquetrum. And in 1871, Henley named the bone hamate. The present nomenclature was proposed by McMurray around the year of 1900, and he also noted that the central form of portion of distal scaphoid in human, and each language continues to use the term that its speaker finds preferable. But the Nomina Anatomica adopted the McMurray version in 1955. He is Rudolf Finnick, a noted anatomist and physiologist, and in 1901 he used a 3-dimensional model based on an angle between the regularized points of individual carpals at end position of each motion on a radiograph. He discovered a 3-dimensional model after the Roentgen discovered a radiograph. he used all the endpoints of radiograph of each bone motion, and he developed the carpal bones, and he describes radio-ulnar motion through both rows of carpal, but he emphasized that proximal row pronate with radial deviation and supinate with ulnar deviation, whereas distal row moved in opposite direction. And he also contraindicated the Henke's theory of mutual perpendicular axis for flexion extension and radio-ulnar deviation. And instead of that, he proposed an oblique axis for each row that intersected in the captate. And he also describes the relative contribution of each row made to total motion in each plane, and he also he also made acknowledge the translation occurred in the sagittal plane at capital lunate joint, which was previously emphasized by Virchow. And he is the person, Ethan Desto, in 1908, suggested that scaphoid and tricuspid acted to connect the pillar bone of the wrist and complete the glenoid for the os magnum. This view of the wrist with scaphoid acting as an intermediary and supporting structure between the two rows endorsed the most of the previous concept and predated the recent oval ring concept of carpal instability. Navarro of Montevideo in 1921, he congratulated the sort of fundamental studies, but he believed that two lateral columns that supported the central column were fundamentally different. So he categorized the flexion extension column represented by capital lunate joint, and in that scaphoid act as a stabilizer of radial column, and triquetrocapital hamate joint as a rotational column. The Navarro's work languished in obscurity until it was brought to attention by Talisnik. The Talisnik is the person who modified the Navarro's theory and slightly and popularized the three-column risk concept. A study done on development and morphology of human wrist in embryonic and early fetal period in 2012 by Fedel, and it was published in 2012. In the study mainly focused on chondrogenesis of carpal ligaments and triangular fiber cartilage. So that in that study, the total number of specimens were 57. Out of that, human embryo were 30 and fetal specimen were 27. The human embryos are staged by O'Reilly staging from 17 to 23, and the fetal species were taken for 9 to 14 weeks for the risk development. The 17 to 23 O'Reilly staging. In this, 17 is the stage 17 is undifferentiated mesenchyme, whereas 18-19 is condensed mesenchyme. 19-20 is pre-chondrogenic stage, and 20 and above is chondrogenic stage. The first image in the picture shows the O'Reilly staging of stage 18. The transaction cut. In this, there is a from the distal to proximal. We can see the apical ridge, development of apical ridge, marginal wings, and premature metacarpals of third and second and third. This is third metacarpal and second metacarpal, and thenar eminence. And this is the carpal mass found by condensed mesenchyme. And this FB denotes the fibrocartilage of the forearm, which is the future development of forearm, fibrocartilage substance, which is the future development of forearm. And medial nerve also, you can identify the medial nerve. The second picture denotes the O'Reilly staging of stage 22. In this, you can see carpal bones. That is, this is the scaphoid, lunate, trapezium, trapezoid. This is the physis of distal radius, and 3 metacarpal with distal phalanx. So, next, this picture in the second first picture, you can this is the fetal human fetal week 9. In this, you can see the abductor pollicis development of abductor pollicis muscles and ulnar deep branch of ulnar nerve. And in this second picture, you can see the development of articular disc between the distal phases of the ulna and the triquetrum, and this layer is the collateral ligament, ulnar collateral ligament. The extensor carpi ulnaris muscle slides, this extensor carpi ulnaris slides on over the ulnar collateral ligament. So in this picture, you can see the aroma which shows is the blood vessels. This blood vessel, this is a human fetal week 14. In this, blood vessels appears inside the lunate cartilage mold. So if you find this one in the cartilage, this depicts the early sign of osteogenic property, and this will develop after the birth. And this is the interosseous ligament between the lunate and the scaphoid, and there is a development of synovial plica and articular disc. You can visible clearly in week 14. Now we are coming to fibrocartilage articular disc. This is the fibrocartilage, which this is the image. The first image picture denotes the overlay staging 23. In this, the articular disc is a thick mesenchymal condensation which appears between the distal ulna and the triquetrum, and it is completely organized in human fetus week 14. And the second picture denotes the human fetus of week 9. In that, you can see the radiocollateral ligament. The 19 denotes the radiocollateral ligament, and the interosseous ligament between the scaphoid and lunate. And there is a radiocaptate ligament. The radiocaptate ligament is perceived in this week. In week 9, you can perceive the radiocaptate ligament, which is known as carpal tunnel floor. And so development of flexor retinaculum, you can visit this. The 20 denotes the development of flexor retinaculum in week 10 of fetal species, and in radio carpal ligament, palmar radio carpal ligament, and 22 denotes the dorsal radio carpal ligament. And the second picture, you can see the articular capsule. This capsule is formed from the intermediate layer. AC is the articular capsule. This capsule is formed from the intermediate layer of interzone, and the capsule, along with the collateral ligament, surrounds the cavity of the joints. And you can note that adductor pollicis, adductor muscles, adductor pollicis, oblique of adductor pollicis reaches the sesamoid of the first metacarpal. This is sesamoid, internal sesamoid of the first metacarpal, and they leads to intrinsic muscle group, development of intrinsic muscle group in this week, in week 12. And coming to the radiocarpate ligament, the radiocarpate ligament is the 25 denotes the radiocarpate ligament. It is well defined in week 13 of the fetal embryo, and this separates the ulnar deep branch of ulnar nerve from the median nerve. And the second image, in this you can see the synovial membrane, which is formed, is a cellular cell layer differentiated from the intermediate interzone, and it is formed in the week 13 of human fetus. So coming to anatomy, this article was published in Germany in 2020. The bones of the wrist are there are 8 scaphoid bone. The proximal row consists of scaphoid, lunate, triquetrum, and pisiform, whereas the distal row consists of hamate, captate, trapezoid, and trapezium. So the ossification of the carpal bones starts from captate, that is from the 6 months of the captate, followed by hamate 1 year or 1 year, and triquetrum 3 years, lunate 4 years, scaphoid and trapezoid at 6 years, and pisiform at 12 years. Captate being the largest bone in the carpal, and it acts as the keystone for the carpal arch. And the bones of the distal row are bound tightly with a strong ligament, and they act as a single functional unit. So this rigid ligamentous connection of the distal carpal ligament, to the base of the metacarpal allows the considering distal carpal function as a unit that moves in response to the muscles or forces of the forearm. The proximal carpal ligaments they behave differently in comparison with they exhibit a significant motion between the adjacent bone, and the entire row moves generally in same direction. The proximal carpal row moves in combination with the distal during wrist flexion and extensions, but it continues experience of during radial and ulnar deviation. The proximal carpal row acts as an intercalated segment between the radius and the dorsal carpal row. Coming to ligament, ligaments plays a crucial role in guiding and constraining the carpal motion during overall movements of the hand. They include extrinsic and intrinsic ligament, where extrinsic connects the carpal bones to the radius or metacarpals, and it includes volar and dorsal ligaments. The intrinsic ligaments originate within and inserted on different carpal bones itself. Coming to extrinsic ligaments, in extrinsic we have volar radiocarpal ligament, volar ulnar carpal ligament, and dorsal ligaments. In volar radiocarpal ligament, we have radiocollateral ligament, radioscaphoid ligament. The radioscaphoid ligament creates a sling to support the waist of the scaphoid, and this ligament is preserved during the proximal carpectomy, and this ligament acts as a primary stabilizer of the wrist after proximal row carpectomy and prevents the ulnar drift. The long radio lunate ligament, it contracts, this starts from the radius and attached to the lunate, and this ligament contracts the ulnar distal translocation of lunate. And radioscapholunate ligament, this ligaments from the radius and to the scaphoid and lunate, attached in the other lunate, and only function as a neurovascular conduct, and it does not add any mechanical stability. But the short radiolunate ligament gives a stability to the lunate. It starts from the radius and attached in the lunate. This short radiolunate ligament give stabilize to the lunate, whereas volar carpal ligaments, then volar carpal ligaments like ulno triquetral and ulno lunate ligament. This ligament prevents palmar translocation of ulna. And coming to dorsal ligaments, in dorsal ligament, the dorsal triquetral ligament is also known as dorsal carpal ligament. This the dorsal triquetral ligament is also known as dorsal carpal ligament. This ligament is disrupted in volar intercalated stability of deformity, and dorsal intercarpal ligament. This is scapholunate. This ligament prevents in scapholunate stability. And coming to intrinsic ligaments, intrinsic ligaments are proximal row, distal row, and palmar midcarpal row. And in proximal row, we have scapholunate ligament. It has dorsal portion and volar portion. In dorsal, prevents translation, and it's a primary stabilization of scapholunate joint, whereas volar portion prevents in rotation. In lunar triquetral ligament, it has two things. One is dorsal and volar. In that, strongest part is the volar when compared with dorsal. And in distal row, there are three ligaments. One is trapezoid ligament, trapeziocaptate ligament, captohamate ligament. This prevent the carpal instability in the dorsal row. Then, when coming to palmar midcarpal ligament, trapezoid ligament, captate ligament, and all these ligaments prevents in carpal instability during the form of injury. And now coming to the muscles, the muscle acting on the wrist joint are situated within the forearm. Only the muscle tendon crosses the wrist and get inserted in the hand and the fingers. There is no tendon directly attached to the corpus on a proximal carpal row. The muscles of dorsal side of the forearm acts to extend, and the muscles of palmar act to flex the wrist. The wrist bone motion depends entirely on the mechanical force from the surrounding articulation. So the there are three this three muscles are the flexion, and this three muscles for extension. The flexion muscles are flexor carpi radialis, palmaris longus, and flexor carpi ulnaris. These muscles origins from the epicondyle of the medial epicondyle of the humerus, whereas the extensor from the lateral epicondyle of the humerus. The flexor carpi radialis muscle inserts in second metacarpal, and palmaris longus, this muscle gets aponeurosis along the palmar aponeurosis and insert in the along with the flexor, goes along the flexor retinaculum and inserts in the palmar aponeurosis, and flexor carpi ulnaris inserts in the hamate, whereas extensor carpi radialis, this muscle gets attached to the second metacarpal, and brevis attached to the third metacarpal, whereas ulnaris attached to the fourth metacarpal. These flexor muscles mainly they are used in flexion and radial. This is used for flexion and radial deviation, whereas this side flexor carpi radialis, extensor carpi radialis longus, and extensor carpi, this is used for radial deviation, whereas flexor muscles of flexor carpi ulnaris for flexion and ulnar deviation. Then coming to vascular supply of the major vascular supply is from longitudinal extraosseous vessels originate from the anterior introosseous and radial arteries. The anterior introosseous artery divides into anterior and posterior branch proximal to the distal radioulnar joint. The primary source of dorsal radius is provided by the posterior division of anterior introosseous artery with radial artery. This supplies not only the joint, it gives nutrition to the soft tissues, and it creates the possibility raising of pedicle flap, and which includes the posterior introosseous nerve, skin, and the muscle. The dorsal vessels are best described on the location in relation with the extensor compartment and the extensor retinaculum. The two vessels are superficially located in location of dorsal surface on the extensor retinaculum. Because of their location, they are said that 1 and 2 intercompartmental supraretinacular arteries and 2 and 3 intercompartmental retinacular. The 1 and 2 intercompartment supraretinacular arteries originates from the radial artery 5 centimeter proximal to the radiocarpal joint and passes beneath the brachioradialis muscles and tend to lie on the surface of the dorsal surface of the extensor retinaculum. So distally it passes beneath the tendon of first extensor compartment to enter the anatomical stuff box and anastomosis with the radial artery. Study done by Mick on the blood supply of human distal radioulnar joint and the microvascular of articular disc. In this study, they took 35 upper extremities from 22 fresh cadaver. Out of that, 11 newborns and 11 adults were taken, and they used Indian ink injection and tissue clearing technique. This microvasculature of articular disc of the distal radioulnar joint was performed in the 35 articular disc of fresh cadaver. They said that the major portion of the articular disc are avascular, and only the peripheral, palmar, medial, and dorsal margin are vascularized. The portion, depending upon the portion of vascular zone to avascular zone, depends on the age of the subject, and mainly in newborns, it approximates for 33%, and in adults for 25%. Coming to the nerve supply, the first image shows the dorsal supply of the dorsal supply nerve root of the wrist. In this, there are 4 nerve, mainly the superficial branch of radial nerve, posterior interosseous nerve, medial antebrachial cutaneous nerve, and dorsal branch of ulnar nerve. Whereas in the palmar side, we have ulnar nerve, anterior interosseous nerve, median nerve, along with that median nerve and palmar branch of median nerve, and lateral antebrachial nerve. In this, they found that the capsule and periosteal networks was supplied by the anterior interosseous nerve, lateral antebrachial nerve, and posterior interosseous nerve. The palmar interosseous nerve of median nerve, and the deep branch of ulnar nerve, and dorsal branch of the ulnar nerve. These 3 things have found to be connection with the capsule, and there is no periosteal nerve branches noted to the capsule and the ligaments. Whereas the median branch of anticutaneous nerve does not have connected with capsule or periosteum, rather than it terminates with the extensor flexor retinaculum. A study done on innovation of wrist joint and surgical preservative of denervation by Jared in this study in Netherlands. In this study, they have done 18 human wrist for microdissection and histological examination. They used acetylcholine esterase method was used to identify the nerve both in whole mount preparation and section, and they found that in chronic pain of the wrist, to denervate the wrist by making 2 incision with one on palmar and one on dorsal incision. It should be possible to disconnect the periosteum from the capsule and interrupt the majority of capsular nerve branches. And coming to the structures which present around the wrist joint, or triangular fibrocartilaginous complex. This is load bearing structure and is located in the medial part of the wrist joint between the lunate, tricutal, and the head of ulna. This is built up by triangular fibrocartilage disc. This is built up by a triangular cartilaginous disc. Along with that, meniscus homologous, ulnar collateral ligament, dorsal radio ulnar ligament, and palmar radio ulnar ligament, and base of extensor carpi ulnaris sheath, and ulnar collateral ulnar lunate ligament. These things acts as a function of to stabilize the ulnar aspect of the wrist joint, and further it prevents the ulnar carpal by transmitting and distributing the axial load from corpus to the ulna, and it facilitates the movement at the wrist. Coming to carpal tunnel, the carpal tunnel has boundaries, the scaphoid, tubercle, and trapezium radially, hook of Amen and pisiform ulnarly, and transverse carpal ligament as a roof or a place in the palmar side, and proximal carpal row as a dorsal side. The contents of the carpal tunnel are 4 flexor digitorum superficialis tendon, and 4 flexor digitorum profundus tendon, and flexor pollicis longus, and main structure is the median nerve. In this, if the carpal tunnel syndrome, if the patient has carpal tunnel, then median nerve has paresthesia in the hand supplying on the palmar aspect of the median nerve. Then coming to Guyon's canal, in Guyon's canal, the course is approximately 4 centimeter, and it begins proximal extent of transverse carpal ligament and ends at the aponeurotic arch of the hypothenar muscle. And it's the ulnar nerve bifurcates into superficial and sensory branches in that zone. the boundaries of the Guyon's canal are floor is by the transverse carpal ligament and hypothenar muscle, whereas the roof is by the volar carpal ligament, and ulnar border is by pisiform hamate ligament and abductor digitory muscles, whereas the floor is by the whereas the lateral border is by the hook of hamate. So the importance of the Guyon's canal is zone. The zone 1, 2, there are 3 zones, zone 1, 2, and 3. Zone 1 is located proximal to the bifurcation of ulnar nerve. Zone 2 is located surrounding the deep motor branch, and zone 3 is in the surrounding superficial sensory branch. So if the Guyon's canal is compressed by ganglion, in zone 1 is mainly it's compressed by the ganglion or hook of hamate fracture, and in zone 2 by the ganglion, zone 1 and 2 by the ganglion hook of hamate, whereas zone 3 is by the ulnar artery thrombosis or aneurysm. If zone 1 is affected, the patient will have mixed motor and sensory deficit. If zone 2 is affected, patient will have only the motor deficit, and zone 3 is affected, patient will have only the sensory deficit. Coming to space of Poirier, this is the center of double V-shaped converged ligament. There are two, this V-shaped converged two ligament. This is the radioscaphocapitate ligament, and this is long radial. Between these two ligaments lies the space of Poirier. This is the central weak area of the wrist in the floor of the carpal tunnel at the level of the proximal capitate. And this, while during palmar flexion, the area of weakness disappear, while during dorsal flexion, the area of weakness increase. This space of Poirier is important because in perilunate dislocation, the space allows the distal carpal row to separate from the lunate, whereas in lunate dislocation, the lunate escapes into this space. And coming to extensor compartment of the wrist, there are 6 extensor compartment of the wrist, and the first compartment contains extensor pollicis brevis and abductor pollicis longus, and it is the most lateral aspect of the wrist joint, and this tendon acts as the lateral border for the anatomical stuff marks, whereas compartment 2 has extensor carpi radialis brevis and extensor carpi radialis longus, and the listed tubercle is a bony prominence in the distal aspect which separates the this is listed tubercle which separates the compartment 2 and compartment 3, whereas compartment extensor compartment has 3 as extensor pollicis longus muscle, which is the medial border of the anatomical stuff box, and compartment 4 has 2 muscles, two tendons, was extensor digitorum and extensor indicis, and whereas the compartment 3 has extensor minimi, and the last compartment has extensor carpi ulnaris. So why we know how to know now? Because during scopy, wrist scopy, we have to know the compartment for the visualization. That this 3 and 4 denotes the placement of the first primary view portal. This portal is located just 1 centimeter distal to the listed tubercle between the extensor pollicis longus and extensor digitorum communis. This in this we can it's a primary portal for the wrist joint, whereas the second is this 4 and 5 is located located in the line of ring finger of the metacarpal and between the extensor digitorum communis and extensor minimi. This portal is for the instrumentation and visualization of triangular fibrocartilage complex. And 6U, this is located radial. 6U is located ulnar to the extensor carpi ulnaris, and it's used for visualization and instrumentation and TFCC of repair, triangular cartilage repair. And 6R is located radial to the extensor carpi ulnaris. In this both 6U and 6U and 6R, ulnar nerve is the most structure at the wrist. And coming to medial carpal portals, these medial carpal portals are used for carpal visualization and evaluate the wrist instability and used for as well. The MCR medial carpal nerve, this is located 1 centimeter distal to the third and 3/4 portal along the long axis of the radial border of the middle finger. And this will allow us to visualize the scaphoid lunate, scaphoid captate, and scaphoid trapezoid. This is for scaphoid with scaphoid lunate, scaphoid lunate, scaphoid captate, and scaphoid trapezoid. Whereas MCU is for visualization of lunocaptate, lunotricutal, and tricutal hamate. And this ST is the ST portal. STT portal is located along the axis of the index finger, and it is used for visualization of only the scaphoid, trapezoid, and trapezial joint. And take home message means Talesnik modified the narrow concept slightly and popularized the three-column concept of wrist. And captate is the largest bone located in the center of the wrist, act as the keystone for the carpal arch, and no tendons is directly attached to the corpus and PCR. And in lunate dislocation, lunate escapes into the space of Poirier, and in carpal tunnel syndrome, medial nerve is affected. Medial nerve is again Guyon's canal. The radial ulnar nerve is affected, and we have to know clearly about 6 extensor compartment for the wrist arthroscopy. Thank you, sir.
Thank you, Santosh. Did you go through any of the previous videos on wrist anatomy and the applied science explained by the wrist arthroscopic surgeons in WUMED?
No, sir.
See, that's the problem. Here, as an orthopedic surgeon, we are worried about, we are more interested in learning or improving our knowledge on the surgical anatomy of the wrist and not the entire anatomy. You have taken a class for an MBBS student first year. That is not what is needed. We wanted from the orthopedician's perspective. So studying everything is not possible, and remembering everything that you have studied is impossible. So you have to stick on to what is very important for you as a wrist surgeon. So you have to split your understanding of the wrist into various segments. Now, apart from trauma, trauma can happen to any of the bones. So we are not worried about trauma. We are worried about the cold cases. What are the cold cases that you come across in wrist? Mostly the radiocarpal or the midcarpal instability. So you have to focus on the extrinsic wrist ligaments, which are important, and the bones, which are very important in contributing to the stability of the wrist joint. So you have to split it accordingly. So see, namely the most important wrist joint bone, which is very important for the stability, the scapho-luno and capitate complex, SCL complex. Now, if that SCL complex is compromised, then the entire wrist is jeopardized. So you have to talk about all the anatomy confined to the scaphoid, to the lunate and the capitoid, and the ligaments which are important with that. And apart from the carpal bones and the ligaments, the next most important ligament, which is commonly seen in our orthopedic practice, is the TFCC. So had you explained just about these 4 things, you would have done justice to your talk, rather than talking everything about the wrist nerves divisions, which even I don't remember much. So you should know what to talk, how to talk, and keep your talk for only 10 to 15 minutes to have the attention of the viewers. Studying everything and talking about everything doesn't make sense. You have to live up to the expectation of an orthopedic surgeon and not as an MBBS student. So this talk is very good for an MBBS first year, but for an orthopedic surgeon, no, definitely not. So in that case, what my genuine advice would be, before any talk that is given to you, log into WUMED, type the talk which is being given to you, and see how the international speakers talk about it, their perspective of understanding this concept, and how they're explaining to the viewers, and how they make the viewers understand this. See, whatever hard work that you have done in studying or reciprocating whatever you have studied here is a waste when it is not understood by the viewers. So you have to make sure that whatever you studied is easily explainable and understandable by the viewers. And what I would say is right now, again, you go back to WUMEDI and list anatomy and type those subjects and see how the international speakers talk about that. That is more important. We'll go to the next talk, please.
Shyam, I want to make one statement.
Yes, sir.
Having done a bunch of wrist arthroscopies, the 3-4 portal is the most important one. And I wish the speaker had shown a video, maybe 30 seconds or 1 minute, to gather and attract the attention of the listeners. Because to view the TFCC on a cadaver specimen is totally different than when you look at it through a 2.7 wrist arthroscope.
Absolutely,
And,
sir. Absolutely.
If you had shown a video of the 3-4 portal and what dramatic things are seen in that, it would have been nice. And as you said, a lot of anatomy. I happen to have done a hand fellowship, so I know much of it, but it's still a little boring for me.
Yes, sir. In the next classes where we'll be discussing about the various aspects of wrist pathology, it will be better if we can add videos respective to that talk, surgical videos, so that you can understand better. You can start your presentation, Arun.
Good morning, sir. I'll be talking about biomechanics and carpal instability. So to start off with some basic anatomy, proximal carpal row. It's made up of scaphoid, lunate, triquetrum, and pisiform. Distal carpal row, trapezium, trapezoid, capitate, and hamate. But when it comes to biomechanics, the distal carpal row is bound by strong ligaments, and it functions as a single functional unit, and it moves in response to the muscle forces. They say from a biomechanically point of view, it's just the proximal extension of all the metacarpals. But it is completely different from the biomechanics and proximal carpal row, which exhibits significant motion between the adjacent bones. And the proximal carpal row, it moves in flexion and extension and radius and ulnar deviation, and it continues to experience flexion and extension motion in radius and ulnar deviation of the radius and ulnar. And they say that the PCR is just the intercalated segment connecting the radius and the distal carpal row. Coming on to the normal motion. So the normal wrist motion has two range of motion, that is in two orthogonal axes. One is flexion and extension. Next is radius and ulnar deviation. As we can see from this picture, all the carpal bones are centered, moves and rotates in close proximity to the long axis of the capitate. So what is a normal ROM? Normal ROM is 5 to 35 degrees of flexion extension and 10 to 15 degrees of radius and ulnar deviation. Regarding the center of rotation, there is a controversy, but many authors say the center of rotation lies in the head of capitate in both flexion extension and radius and ulnar deviation. So having said that, how does motion occur at PCR? The proximal carpal row doesn't have any muscle attachments as quoted by the previous speaker. Then it depends mainly on the mechanical forces from the surrounding articulation, and the motion should be initiated at the distal carpal row. The motion should make sure that the extrinsic ligaments are made taut, and the forces acting on the proximal carpal row should be greater than the frictional forces and the antagonistic muscle. Only then it moves. So coming on to some basic theories, they say for movement in carpal bones. First is row theory. This is the summarization of what I've spoken previously. It is basically dividing carpal bones into two rows, proximal and distal. Distal being surrounded by stout ligaments, it moves in response to the muscle actions of the forearm. Coming on to column theory, it is by Navarro in 1921. He divided carpal bones into 3 columns. One lateral column is by scaphoid, trapezium, and trapezoid, and flexion extension columns by the lunate, capitate, and hamate, while the medial column judges for the rotation, triquetrum, and the pisiform. Next comes the row column theory. Row column theory is modified by Telesnik et al. It is basically a modification of Navarro's. Here, the author has added trapezium and trapezoid to the central column, which is mainly responsible for the flexion extension. And he eliminated pisiform from the medial column. The author specified importance to the scaphoid and the triquetrum because the scaphoid functions as a stabilizing link for the midcarpal bone, while the triquetrum acts as a pivot point for the carpal rotation. Next comes the ring model. Ring model, it is based on the concept that if at all, if radius and ulnar deviation movement happens, the opposite movement, that is flexion and extension, happens at the carpal bones. Say, if the wrist is put into radius and ulnar deviation, the proximal carpal row will go for from flexion to extension. So this is the basis of the ring model. And the authors, they say the movements, it's by the 2 mobile links. The first mobile link is by the trapezioscaphoid, and the second mobile link is by the triquetrohamate. And they also emphasize the importance of intercarpal ligaments, which is essential for the proximal carpal movement. And any interruption, especially in the proximal carpal row, will result in carpal instability. Next comes the link joint theory. Link joint theory is by Guilford et al. It's basically, they have considered wrist joint as a link between the radius and lunate, and capitate. And under axial forces, there is the link compressed in a zigzag manner, unless and until there is a control rod to stabilize it. And they say scaphoid functions as the control rod in order to prevent the collapse of the carpal bones. Next comes your ovoid or C-shaped theory. This is by Moritomo. It is a MRI-based study. They say the midcarpal motion lies in the shape of an ovoid, and it consists of 2 motions, that is uniaxial and biaxial. Uniaxial is between the scaphotrapezoid joint, and the biaxial movement is between the lunate and triquetral. And they also emphasize the importance of intercarpal ligaments in proximal carpal row, as same as the previous author. And they say if at all, if the midpoint of all these, the midcarpal scaphotrapezioid ligament and the lunotriquetral ligaments are joined, it attains a shape of a sheet, and it attains a shape of C, and the main axis runs from radiopalmar to ulnar dorsal direction. Next comes your screw-wise or clamp theory, McConnell et al. It's by McConnell et al. In 1941, in which he divided carpal bones into 3 masses. He gave importance to the scaphoid separately, and lunate and triquetrum in another mass, and hamate, capitate, and trapezoid in another mass. Here, what happens is when the wrist is put into hyperextension, the scaphoid becomes a vise. It pins the distal carpal row, and hamate acts as a screw, and it pins the lunate towards the scaphoid. So this theory, it's basically a clamp. It's also called a black clamp theory, explaining the importance of scaphoid and the hamate in hyperextension of wrist joint. So, having said that, what my take on these theories is, no study has described the carpal motion in comprehensive carpal motion, and each paper has quoted some part, only some part, not a comprehensive part. And coming on to what happens in what happens to the stresses in wrist in neutral position and forearm in neutral position, neutral rotation. 80% of the force goes to the radiocarpal, of which majority goes to the radioscaphoid. What happens in the midcarpal joint is about maximum force goes through the scaphotrapezioid joint, and followed by the lunocapitate joint. So coming on to the topic proper, pathomechanics of carpal instability. We all know the VC and DC. VC stands for volar intercalated segmental instability, and DC stands for dorsal intercalated segmental instability. This is nothing. This is basically in DC there will be a dorsal tilt of the lunate, and in VC there will be a volar tilt of the lunate. Coming on to some angles, scapholunate angle and the capitolunate angle. The scapholunate angle, which is shown in blue and red, it's this is the angle between the volar aspect of the scaphoid and the axis of the lunate. Normally, it is 30 to 60 degrees, and the capitolunate angle is at the angle formed between the long axis of capitate and the long axis of lunate. And the normal is 0 degree, that is linear. So what happens in VC and DC is in DC, because of the dorsal tilt of the lunate, the the scapholunate angle gets increased, and the capitolunate angle also it's increased. It's more than 30. And when it comes to VC, because of the volar tilt, the scapholunate angle gets decreased, but the capitolunate angle gets increased. So many authors say this classification of carpal biomechanics is very simple, and the carpal instability is much more beyond just VC and DC. So they have classified carpal instability into four major types, that is carpal instability dissociative, non-dissociative, adaptive, and complex. So what do you mean by carpal instability dissociative? It's basically injury to the intrinsic ligaments that alters the biomechanics within the same carpal row. In non-dissociative, it is injury to the extrinsic ligaments. The biomechanics between the radius, either the radius and the proximal carpal row, or the between the proximal carpal and the distal carpal row is disturbed. And carpal instability adaptive, there is the pathology lies outside the corpus, that is basically in malunited distal radius fracture, where there is exaggerated dorsal tilt. And carpal instability complex, it's basically a combination of dissociative and non-dissociative pattern. So coming on to some important topics in dissociative. First is scapholunate dissociation. So what happens in scapholunate dissociation? The injury is with hyperextended wrist with ulnar deviation. So for a scapholunate dissociation to occur, there should be injury to the scapholunate interosseous ligament, most importantly dorsal, which is the strongest bone. The volar is flimsy, but it is they say it is responsible for the rotational control. And scapholunate dislocation may occur in isolation or starting stage of carpal destabilization around the lunate, which is given by Mayfield's in his 4 stages, which I will be talking a bit later. So what happens in fall with the hyperextended wrist with ulnar deviation? There will be damage to the scapholunate interosseous ligament. There will be some micromotion between the scaphoid and the lunate, but it will be secondarily stabilized by the secondary stabilizers, such as the long and the short radial ligament. But even with due course of time, if it goes for attrition, even the secondary stabilizers, they become attenuated, and it results in DC, that is dorsal tilt of the lunate. And in advanced cases, it results in scapholunate advanced collapse. This is a picture showing scapholunate advanced collapse, where we can see the osteophytes between the scaphoid and the radial sigmoid with scapholunate gap of more than 5 mm. So what are all the tests? This is the scaphoid shift test, in which the examiner applies pressure over the scaphoid tubercle, and the wrist is put into radius and ulnar deviation. And while doing it, while applying pressure, the scaphoid tubercle displaces, and if the pressure is relieved, it gets relocated with a clunk. That signifies the injury to the scapholunate ligament. Next comes your lunotriquetral dissociation. Lunotriquetral dissociation is with fall on the hyperextended wrist with radial deviation. Basically, because of the fall, the impact falls on the hypothenar eminence. So the pisiform is driven straight into the triquetrum. However, the lunate is stable because of the long and the short radiolunate ligaments. So the majority of the force is happens to the lunotriquetral ligament, which gets ruptured. But does the rupture of lunotriquetral ligament alone results in VC? The answer is no, because they say that for VC to happen, there should be rupture of some volar carpal ligaments also in addition to the lunotriquetral ligament. And patient will preferably say the pain are ulnar deviation and axial compression. This is the Ballotman test. We can see that they use for checking for the stability of the lunotriquetral ligament, in which the examiner holds lunate and triquetrum and he ballots it. If there is pain and if there is excessive ballotment, it signifies injury to the lunotriquetral ligament. Coming on to the non-dissociative part. So non-dissociative is injury to the extrinsic ligaments. So normally in ulnar deviation, as I said earlier, if the wrist is going in for ulnar deviation, there will be flexion extension motion happening at the proximal carpal row. So in ulnar deviation, normally the proximal carpal row goes from flexion to extension. However, in case of injury to the triquetrohamate capitate ligament and scaphotrapezium ligament, this motion is this motion is disturbed, and the proximal carpal row still lies in flexion. However, if the wrist is put into extremes of ulnar deviation, the proximal carpal row reduces back with a clunk, signifying the carpal instability. Next comes your DC in non-dissociative. DC happens because of the injury to the dorsal intercarpal ligaments and the radius scaphocapitate ligaments. Here, the proximal row remains aligned through with the wrist throughout the motion arc. So what happens here is it is the capitate that is dislocating dorsally, not the proximal carpal row, resulting in DC. Combined form is the proximal the proximal carpal row relocating in extremes of ulnar deviation, and dorsal subluxation of capitate forms the combined form. And coming on to the next is ulnar translocation. It is basically the injury in hyperextension, pronation, and ulnar deviation. There are two types. In type 1, the whole corpus is dislocated towards the ulna. In type 2, there is injury to the scapholunate ligament, and the scaphoid and the radius remains attached, while the rest of the corpus moves towards the ulna. Coming on to midcarpal instability. In midcarpal instability, there will be a dysfunction of both radiocarpal and the midcarpal ligaments. Type 1, there will be a dorsal tilt of the lunate, ventral tilt, volar tilt of the lunate. In type 2, there will be a dorsal tilt of the lunate with dorsal subluxation of capitate. The type 3 is basically the exaggerated form of type 2. In type 4, there will be an additional dorsal tilt of the radius in addition to this type 3. Coming on to carpal instability adaptive. Adaptive as in the pathology lies outside the corpus, and this is usually seen in radius fractures, malunited radius fractures with excessive dorsal tilt. So what happens is the excessive dorsal tilt in the radius, it loosens the midcarpal ligament, which is usually taut, and proximal carpal lies in flexion during the entire ulnar deviation. It doesn't go for extension, and there will be a dorsal translation of capitate and the distal row. Coming on to carpal instability complex. It is a combination of both carpal instability dissociative, that is injury to the intrinsic, and non-dissociative, that is injury to the extrinsic ligaments. They say there are 4 categories in carpal instability complex. One is dorsal perilunate dislocation, which is also called as lesser arc injuries. Lesser arc injuries were basically injuries to the ligaments alone. And if it is associated with fracture, they call it as greater arc injuries. And it could dislocate palmar also, which could be purely ligamentous, or it could be associated with some fractures also. And finally, axial dislocations. Here comes the Mayfield stage. In Mayfield stage, when the wrist is put into hyperextension, all the ligaments are taut, which puts a scapholunate ligament under stress, which goes for disruption. So stage 1 is by the disruption of the scapholunate ligament. And the force continues if the wrist is still going in for hyperextension into the space of posterior. So in which there will be a disruption of the lunocapitate ligament also. So that signifies the stage 2. If the wrist is still going on for hyperextension, the lunotriquetral ligaments is put under a lot of stress, which also goes for disruption. So stage 1 is scapholunate, stage 2 is lunocapitate, stage 3 is lunotriquetral. And what happens in stage 4 is there will be a disruption of the dorsal carpal ligaments also. So when it happens, it pulls the proximal carpal row into its reduction position. But once the proximal carpal row comes back to its position, the lunate is dislocated. So the stage 4 signifies the dislocation of the lunate bone. And this is an extrapolated study by Hertzberg, in which he termed the perilunate dislocations as stage 1 and lunate dislocations as stage 2. He's further subclassified stage 2 if the rotation of the lunate is less than 90 as A, and if it is more than 90, it is B. Coming on to the last topic, that is traumatic axial dislocation injury. It is actually a high energy crush injury in which a longitudinal force acts on the wrist and the carpal bones. The thing to be noted here is there will be an avulsion of flexor retinaculum, making the transverse carpal arch very flat. And there are two major patterns, and this is basically by the direction of the unstable column. In axial radial dislocations, it is the radial column that dislocates. The first three images depicts the radial dislocation. It can happen peritrapezoid, peritrapezium alone, or transtrapezium through the fracture of the trapezium bone. In axial ulnar dislocation, the ulnar column gets dislocated while the radial column stays intact with the wrist bone. It could be transhamate periphysiform. It could be periphysiform hamate and perihamate with the fracture of the triquetrum bone. The take-home message will be the wrist has a complex anatomy, but even more complex biomechanics. There are no comprehensive model for explaining about the biomechanics. Each studies have quoted only the partial function, and the wrist biomechanics is much more beyond that. For us to understand some basic point is distal carpal row is very stable, and proximal carpal row it's mobile comparatively, and a note on VC and DC is VC volar tilt, DC is dorsal tilt. Carpal instability dissociative is injury to the intrinsic, non-dissociative is injury to the extrinsic ligaments, and adaptive is it's the pathology lies outside the carpus, and in complex injury it is a basically combination of dissociative and non-dissociative. And even though it is complex, understanding anatomy and biomechanics is imperative for treating carpal instability. Thank you, sir.
Thank you, Ron. That was a very good presentation.
Thank you, sir.
Made us understand the concepts very well. Now, as such, wrist joint is very complex, and as you said, the biomechanics is very difficult to understand. But salient features would be to understand VC and DC properly, especially the dissociative and non-dissociative one. Adaptative is usually as a result of radial malunions, and which can be corrected with the radial correction as such. As I said before, focus mainly on the scaphoid, lunate, and capitate. These three bones in one plane will ensure the stability of the wrist joint. And anything hampers the stability of these three bones articulation is the one which is going to cause a lot of trouble. So we will in the future classes we'll be understanding the importance of the scapholunate ligament, the lunotriquetral and the capitolunate ligaments, etc. So as such, now we know what is VC, what is DC. Based on that terminology, we will be understanding the importance of the ligament which contribute to the stability, and then we'll know what are all the methodologies in fixing them acute or reconstructing them in a chronic situations.
Good morning, sir. Today I'll be presenting the topic on lumbar spinal stenosis. Coming to introduction, sir. Degenerative lumbar spinal stenosis refers to narrowing of the spinal canal due to degenerative changes in the spinal joints, intervertebral disc, and ligamentum flavum. Verbiest is credited with coining the term spinal stenosis and the associated narrowing of the spinal canal as its potential cause. Kirkland Willis subsequently described the degenerative cascade in the lumbar spine as a cause for the altered anatomy and pathophysiology in spinal stenosis. The term spinal stenosis actually refers to an anatomic diagnosis. Coming to the anatomy, spinal canal is mainly formed by anteriorly by the vertebral body, intervertebral disc, and posterior longitudinal ligament, laterally by the pedicles, lateral ligamentum flavum, and intervertebral foramen, posteriorly by the facet joints, ligamentum flavum, and the lamina. Basically, there are three typical shapes of the spinal canal, which is a round and ovoid and trefoil. Round and ovoid have the maximum diameters, where trefoil canals have the smallest cross-sectional area. The spinal canal contains the thecal sacs. Thecal sac contains the corticosteum then these nerve roots are arranged in the thecal, are present in the central and posterior position. The stenosis is classified anatomically as central, lateral recess, and foraminal. Coming to the pathophysiology, degenerative lumbar spine stenosis is a progressive disease where involves the movement segments of the spine. Kirkland and Willis theory devised that a spine has a tripod when the disc and the two facet joints make up the three limbs. When the disc gets a circumferential or a radial tears in the disc, along with biochemical changes in the disc, the process further goes for the degeneration of the disc and loss of disc height. This results in the bulging of the disc and the posterior longitudinal ligament, which in turn results buckling of the flavum and settling of the facet joints. And over a period of time, when these facet joints settle, there is a facet joint degeneration and hypertrophy and osteophyte formation, which further narrows the spinal canal. Calcification or thickening of the ligamentum flavum is an important mechanism in the stenosis. The study conducted by John Abbas stated that joint trophism can also be a factor leading to degenerative lumbar spinal stenosis. Coming to pathophysiology, once the lumbar canal stenosis happens, there is a mechanical force or circumferential compression happening. This occludes the subarachnoid space. The subarachnoid space actually contains the CSF and the blood vessels. This results in mainly the circulatory disturbance and the injury to the nerve fiber. Circulatory disturbance further lead to breakdown of the blood and nerve barrier, which resulting in intraradicular edema and increased endoneural pressure, which in turn result in conduction disturbance and ectopic discharges. These finally result in symptoms of deep muscular pain, weakness, loss of sensation in the lower limbs, which ultimately results in a neurogenic intermittent claudication. Coming to classification, this is the international classification of lumbar canal stenosis, where it was classified into congenital, acquired, and combined. Congenital mainly included the idiopathic, achondroplastic, and osteopetrosis. Acquired were again classified into degenerative, iatrogenic, and miscellaneous disorders, including the trauma was also included. And a combination of these three was classified separately. Coming to clinical features, leg pains, either neurogenic claudication or radicular leg pains. Neurogenic claudications reports of pain, heaviness, cramping, numbness, burning, or any weakness in the legs. Radicular pain usually with the dermatomal distribution was seen. The most common being the L5 nerve root compression with lateral recess stenosis. Patient also presented with a low backache. Bowel and bladder distances are very uncommon in stenosis. Coming to neurological and coming to differentiating the neurological claudication with vascular claudication. The pain type usually is aching, burning, or paresthesia in neurological claudications. Vascular claudication will more or less a calf tightness or cramping. The walking distance will be variable in neurological claudication, whereas in vascular claudication, it is a constant. The bicycle test or treadmill test, where bicycle generates minimal symptoms, whereas in vascular claudications, it generates similar symptoms. And the pulses, in vascular claudication, the pulses will be diminished, whereas in neurological claudication will be more or less normal. Coming to the management part, investigations mainly include radiography, the AP and lateral flexion extension views of the lumbar spine. The X-ray is mainly taken to look for change, any spondylitic changes or any scoliosis, spondylolisthesis or ankylosis of the spine, including ossification of ligamentous structures. CT scan with or without myelography. Before the advent of MRI, CT was the choice of study in pathological anatomy of in axial cuts. The diagnostic utility actually improved with myelography. Preoperative complete contrast block on a CT myelogram has been correlated with improved surgical outcome. The invasiveness and radiations of the CT scan were the two main backdrops of the study. At present, MRI is the diagnostic modality of choice. It is non-invasive, provides images in the axial plane, coronal, and sagittal plane. They provide both bony and soft tissues anatomy. The sagittal diameter 12 mm was considered as a relative stenosis, and 10 mm or less was considered as an absolute stenosis. This was a study conducted by Manion, where he classified the lumbar canal stenosis based on the CSF and the rootlets floating in the CSF in the axial cuts of the MRI. He graded them into 3 or 4 grades, where grade A was the CSF was clearly visible and the rootlets usually used to float in the CSF. Grade B, there was a clumping of the rootlets with some CSF visible. Grade C, the rootlets were not visible and CSF was not visible. Only the epidural posterior fat was visible. Whereas now the grade D, the rootlets were also not visible and CSF was also not visible. This was categorized as extreme stenosis. Coming to treatment, non-operative treatment was mainly included for mild to moderate symptoms. It mainly included in bed rest, medications using non-steroidal anti-inflammatory drugs, muscle relaxants, and anticonvulsant and antidepressants, orthosis or physical therapy. Lumbar flexion exercise, isometric flexion and isometric extension exercise. Study conducted by Israel Kelenzi et al. Showed the effect of Pilates exercise training program in the trunk extension and flexion strength in stenosis patients. The results were there was an increased strength persisted for 2 months, and there was a decrease in low back pain and improved in functional condition of the patient. Coming to epidural steroid injection, it's an intermediate step between a conservative and surgical management. It is believed that inflammatory reaction and edema is present at the stenotic segment. The epidural steroid injection was put in view of a reduction of leukocyte migration, inhibition of cytokine production and release, and cell membrane stabilization. This study by John Woolley stated that there was a short-term relief of symptoms in approximately 50 to 87% of the cases who had gone through epidural steroid injections. Come to surgical indications, failure of conservative treatment trial for more than 3 months, pain due to walking, weakening of the muscles, and paresthesia of the buttocks and lower limbs. The main principles in spinal stenosis surgery was sufficient decompression of the neural structures. Fusion was considered when associated with instability due to any spondylolysis or any spondylolisthesis or scoliosis. Fusion was also considered when there was any adjacent segment disease associated with the stenosis. Laminectomy is a gold standard surgery for any stenosis when not associated with any instability. Laminotomy was useful primarily in foraminal stenosis. Fenestrations usually preserve the midline structure and minimize the soft tissue injury and bony resection while addressing the sites of neurologic compression. Laminoplasty, where the spinal canal area of the spinal column was increased. It mainly included a distractive type and expansile type. The distractive type involved where after resecting the spinous processes using a lamina splitter, the lamina was opened up and the undercutting of the lamina was done, just decompressing the stenotic segment. And in the expansile type, the lateral gutters were created across the besides spinous process. One side there was a hinge created and the other side was open, and the using a open door technique, the hinge was opened up one side and room for the lumbar spinal canal was created, and later it was fused with graft. We using a autograft. It was tied with laminar wires. Now, over-the-top decompression is a newer technique of decompression where it minimizes the resection and injury to the tissues, which are not directly involved in the pathological process. It is safe, and thorough decompression of the neural structures located in the degeneratively stenotic spinal canal was done. We enter through one side unilaterally into the lamina, and undercutting of the spinous process undercutting of the spinous process was done, and the flavum hypertrophy and the facetal degeneration were taken off through a single approach. Coming to conclusion, lumbar spinal stenosis is a clinical diagnosis. Most patients with radiographic stenosis do not exhibit symptoms of pseudoclaudication. Most patients do well with non-operative care without catastrophic neurological decline. Ideal surgical candidates have symptoms of neurological claudication in distribution that correlates with the radiographic findings. Fusion should be performed in conjunction with decompressive laminectomy in presence of any instability. Thank you.
Dr. Sriram?
Dr. Sriram is not there.
Sir, good morning, sir. I think Shashi is there. I think sir is not online, sir.
Yeah, no, you'll have to wait for your consultant, and then only then you can present.
Okay, sir.
In future, please.
Yes.
Is that all you want to wind up?
Yeah, nothing much to discuss in that topic without Sriram. So we'll wind up.
Yeah. What's the relevance in, secondly to spinal, the listhesis and the athlete?
I mean, stable, whether it's stable or not is the thing. With they have a risk of progression, and the type of listhesis has a significant thing. They can play with some protection. It depends on the type also.
No, but elite guys cannot continue, isn't it? But with the surgery, can they get back?
They can, sir. I mean, Sachin did not undergo surgery. But there's a example of one more player who did. I mean, if it's a traumatic, post-traumatic, or repetitive stress, they need surgery to stabilize because they need fusion. But if it's dysplastic, they carry a high risk. I'm not sure whether surgery will be beneficial or not. Sashi, you have any idea?
Yes, sir. Surgery will definitely be needed, sir, because the athletic activities and all will definitely increase. I mean, progress grade. So usually post surgery by 6 months, I think they can get back to their activities. We have
surgical technique wise, any difference for an athlete and regular person?
No,
When
sir.
fusion is required, instrumentation.
Yes, sir.
Instrumentation. Do you need implant removal before they start playing again? Because
No, sir,
chance of implant breakage.
No, sir. Implant removal is done only in cases of traumatic compression fractures or something like that. Sir. If it's an instability, then we can't actually remove the instrument.
There's a swimmer from Bangalore. I forget the name. That girl. I mean, the sisters were very, 5-10 years back. They were very. She had a listhesis, got surgery done in Ganga. She could never go back after that.
We have few patients, sir, who are bodybuilders by profession, actually, who got operated long back, and they are actually doing with their fitness classes and bodybuilding classes and sessions.
Okay, then you want to wind up?
Yes, sir. So we'll end the session.
Yeah.
Thank you.
Thanks, Gopal. Good night. Thank you.
Good night, sir.
Good night.